Any abnormal symptoms, anything that doesn't feel good, doesn't feel normal, doesn't go away, anything that's lasting longer than 2 or 3 weeks deserves an evaluation. So for women, if they have a strong family history of breast or ovarian cancer, then they need to get screened very closely. If a family has a history of thyroid cancer, they have to get screened very closely. And then you have other risk factors. So for example, you use tobacco, you use alcohol. If you, for example, chew pan, if you are a person who has hepatitis B, these are patients again who are at risk for cancer, so your screening has to be a little more aggressive in those patients. So most cancer screening would start between the age of 40 and 50. If you haven't quit yet, you really need to go get yourself evaluated. You need cancer screening. One more thing that people also don't realize is that once you quit tobacco and alcohol, the cancer risk doesn't fall immediately. It takes nearly 10 years to plateau out. So if you're a young person with thyroid cancer, for example, even if you're filled from head to toe with cancer cells, you can be cured. So if you have metastatic thyroid cancer, if you're a person at the age of 55 who has lung metastasis, bone metastasis, your scan looks like a Christmas tree, you will still be alive at 20 years. I think as oncologists, if we are honest to ourselves, all of our treatments have side effects. Nobody escapes without any side effects.
So my first question to everybody is, in every guest of mine, is if you were not a doctor, what would you have been?
Good question. Not a very easy question. I was very interested in medical science, so maybe something in biomedical engineering. I was pretty bad at math, so I don't know how I would have survived the mathematics component, but I was always interested in medical device and medical technology, and I think I made a foray into that in spite of being a medical doctor. But something around life sciences, definitely.
Okay, how come? I mean, you're from a family of artists, right? So
Yeah, so somehow I always found medical science fascinating. My father incidentally studied medicine but never practiced, so that was some link that I had to medicine. But I always knew from a younger age that I didn't want to be in front of the camera or on stage. I would rather be behind the scenes or treating patients. So for me, from early on, my interest was always in science and in medicine.
okay, I'm glad that you've been into this world, and there's a lot we would discuss what you've done and what you intend to do further after that. So my first question, now you know that the numbers have gone up. The cancer, the rate at which it has increased, I see that every family has one person, two people. So there's no limit to it, and everybody has this question: why me? Like I was saying, looking at cancer numbers itself is kind of shocking. But before we get into what exactly is that, so can you briefly tell our viewers, readers, listeners on what is the status right now, like the cancer scenario in India especially?
So when you look at the numbers in absolute terms and you look at the growth of those numbers, it is a bit scary. So we know a couple of things. We know that the number of cancers that we diagnose each year is going up, and we know that's across multiple cancers. So there are a couple of parts to that. One part of it also is that we are detecting more and more patients. So what that means is, as our diagnostics get better, more and more people have access to the tests that tell them that they have cancer, and more people have access to healthcare. That absolute number goes up. But if you look at the number of patients with cancer going up in a country like India, it is a little bit alarming. There are multiple reasons for that. Some are the carcinogens that we are exposed to. So tobacco and alcohol are still a big problem. Air pollution is a big problem. Obesity is a big problem. Where we have really made strides is in vaccination. So, the rates of liver cancer and liver cancer related liver failure and liver transplant have come down because people have been getting the hepatitis B vaccine. The HPV vaccine has reduced the incidence of HPV infection, and the cervical cancer rates are coming down. So we are getting better at treating some of these, but overall the rates are a bit high, and we have to address these by addressing the root cause of the problem, which is, often things that we can do to prevent cancer, not waiting for the disease to pop up and then jump into treatment. but really thinking how do we live healthy lives so that we never end up getting diagnosed with cancer, or even if we do, we can tolerate that treatment and have a high cure rate.
So the first question that came to my mind when you were saying this, and also a lot of listeners also might have this question, you said healthy lifestyle, and you gave a couple of reasons why there could be cancer, the increase in cancer, right? But my question is, a lot of people these days, you see that, they will have a healthy lifestyle. The same question comes when it is to do with heart attacks as well, right? So where do we draw the line and say, okay, I'm very fit, yet I see that there is a cancer that's come, I mean, that I've been told that I have cancer of whatever kinds. So, how is that happening?
Well, so good question. This is a question that patients ask us all the time, right? We don't have any vices. We don't have any exposures. Why us? Why do we have cancer? So there are two parts to that, right? So the first question is, what's the point of being healthy if anyways we get cancer? So let's address that first. So the whole point of being healthy is that even when you are detected to have cancer, your chance of survival is a lot higher because you can tolerate the treatment better. So if you have a healthy 60-year-old who has never touched tobacco and alcohol, exercises every day, and they're detected with an early cancer, the chance of tolerating and completing that treatment, the survival for a patient who is healthy and fit is much higher than a person who has, say, 3 stents and is in a wheelchair. So there's always a value to being healthy, irrespective of the fact that unfortunately cancer doesn't discriminate. And the second part of that question is, why do people who don't have any exposures get cancer? And that's a much harder, question for us to answer. But at a fundamental level, cancer is an umbrella with a lot of diseases under it. We tend to simplify it by calling it one disease, but it's really not one disease. It's many diseases. Even if you look at a particular area, like the mouth, there are so many types of mouth cancer. We have the common ones and the uncommon ones. So commonly what happens is, cancer essentially at a fundamental level happens when our DNA gets damaged, right? So our DNA can get damaged either through aging, it can get damaged through external factors like carcinogens. So you can have tobacco, you can have alcohol, you can have air pollution, you could have ultra processed food. So our body has the ability to repair damage intrinsically because this happens to us throughout our lifetime. When our ability to repair this damage is outpaced by the damage, that's when you get abnormal cells. These abnormal cells proliferate without being checked, and then they escape the immune system. So when you have this process, you go from having mild DNA damage to having a life-threatening cancer. So anywhere in this entire cycle, there are multiple checks and balances that our body has. So it could be any one of these that basically is out of balance, and that's why we get cancer. So the point is, even if you don't have any so-called traditional risk factors of cancer, many of these are not familial. Only about 5 to 10% of patients have some risk that is passed down from one generation to the other that they'll again pass down to their children. 90 to 95% of them are called sporadic, which means that there is some DNA damage that results in these abnormal cells being formed and then going on to become a cancer.
Okay. That's a very easy and I think better way of explaining this. So then let's stick to something where we know that there has been certain things that you have done and you've got this particular cancer. That, like you said, cancer is a very umbrella. I mean, it has lots and varieties of it. So today's discussion is going to be more on some of the general aspects of cancer so that we can understand it better. So my another question is, are there any early signs of cancer that people are usually, they miss that sign? Is there something that you see in your clinical, and you meet your patients that there is something, this could have been an early detection if the patient had spotted?
Understood. So again, if we look at this, the simplest thing is to understand your body and understand when you have abnormal symptoms. So when we talk about early warning symptoms of cancer, we are generally focused on the common cancers. So the common cancers are, for example, cancers of the breast, where women can have a breast lump, they can have some kind of discharge. The other common one is, for example, oral cancer, where you can have a lump in your mouth, you can have a white patch, you can have a red patch. Colorectal cancer is quite common, so you can have abnormal passage of stool, you could have passage of blood, you could have an alteration in bowel habits, it could be constipation, it could be diarrhea. You have gastric cancer or esophageal cancer, where you have a change in your diet habits. Sometimes you can have bloating, you can have long-term acidity. So to put it quite simply, any abnormal symptoms, anything that doesn't feel good, doesn't feel normal, doesn't go away, anything that's lasting longer than 2 or 3 weeks deserves an evaluation. No panic, doesn't mean that it's cancer. Most of the time it's not, but it needs to be evaluated by a doctor, not necessarily by an oncologist. You should have a doctor who sees you, triages you, and then if there's a suspicion of cancer, then refers you to an oncologist. But since cancers are in every shape and form, it's better not to neglect any odd symptoms that you have for more than a couple of weeks. It's better to get it checked out by a doctor. It can just be a general physician or your internal medicine specialist or a general surgeon who will then evaluate you.
Okay. So, are there any particular tests? Like nowadays, there are so many tests administered for so many reasons. And then we also talk about a routine check, like a routine test. So, there is routine blood test. Then there is some of these special kind of tests also, which is done post these routine tests. So, for cancer detection, is there any test at all?
So, for screening, which means that we look for cancer in patients who don't have symptoms, we do have guidelines based on the geography and the risk factors of the patient. So, for example, in India, it is advised that women over the age of 40 do get mammographies, which are a routine scan of the breast. In younger women, it's an ultrasound scan. In older women, it's a mammography, which is a type of specialized X-ray. So that is one thing. For prostate cancer, you have something called prostate-specific antigen, which is a simple blood test which the tumor tends to secrete and is found circulating in the blood. You also have something called a digital rectal exam, which means that you have a surgeon who will basically feel for an enlarged prostate and tell you if you have prostate enlargement. For oral cancer, it's a simple examination of your mouth by a specialist. It can even be by a trained dentist or an ENT. It doesn't have to be by an oncologist. Oral cancer screening is generally limited to people who have high risk features. So people who use tobacco and use alcohol. Lung cancer screening again is usually restricted to patients who have a history of smoking, and that we screen for using a CT chest. So it's called a low dose CT, which means the amount of radiation in that CT scan is very low. It's a simple chest X-ray that looks at the entire lung and looks for nodules. So we do have very good tests. I think it's important for us to each sit down and think about how we evaluate ourselves. There's no cause for panic, but everybody's risk factors are a little different. So it's hard to generalize. So depending on, number one, what your familial risk is. So for women, if they have a strong family history of breast or ovarian cancer, then they need to get screened very closely. If a family has a history of thyroid cancer, they have to get screened very closely. So first and foremost, your familial cancer link, which usually applies to a small percentage of patients, it's not the vast majority. And then you have other risk factors. So for example, you use tobacco, you use alcohol. If you, for example, chew pan, if you are a person who has hepatitis B, these are patients again who are at risk for cancer. So your screening has to be a little more aggressive in those patients. But otherwise, the best thing for a lay person to do without any increased risk is to be aware of your body, be aware of the symptoms, and get evaluated at the earliest chance when something feels off.
So is there any age that you're looking at when you're looking for screening of cancer? Like you said, familial cancer, I understand that maybe after I don't know, I mean, if you have, there is a number to it saying that, okay, these days you talk about, after 30, get your heart checked, get your, lungs checked and
yes.
things like that. So is there any age per se?
So most cancer screening would start between the age of 40 and 50 based on what kind of cancer we are dealing with. And it varies from government to government, what kind of guidelines we're dealing with because of the risk factors of individual populations. So I think if you look at low risk screening, as in non-invasive screening, so for example, for colorectal cancer, you have something called, which is basically fecal occult blood, which means it looks for traces of blood in the stool, which is a simple stool test that most people would do even in a pre-employment examination. So that is a non-invasive test. I think the risks of doing that are very low as opposed to a colonoscopy or something that's invasive. So I think our threshold for doing these kind of screening tests periodically when they're non-invasive and the risks are quite low should also be low. So there should be very little hesitation to look for these. I think very often the minute anyone says cancer, there's a lot of stigma and fear, and we'd rather not know than know. So I think that has to change. Cancer, whether we want to accept it or not, is a very common problem that patients suffer from. But the flip side of that, it is a very treatable, very curable disease. So the vast majority of our patients do very well with treatment. They go on to have long and meaningful lives. So it's not a death sentence, but the single most important thing that we can do to ensure that we live long and well is to pick it up early. So the stage at diagnosis determines survival significantly. So if you pick it up early, find a small tumor, you can be treated with as little side effects as possible and have a very good quality of life and a long life.
So coming back to the question on screening, I know it might sound very repetitive, but a lot of people, especially who smoke and drink, all their question is, I do it occasionally, so do I still have to screen for cancer? So is there any, one is definitely the family links that you're talking about. Are there any other things that a person who smokes and drinks alcohol should consider?
Consider quitting. That's the first and foremost. And the reason for that is very simple, because smoking and alcohol again both damage our DNA. So the rate at which our DNA gets damaged varies significantly from person to person. So I could smoke 1 cigarette a day and you could smoke 10 cigarettes a day and I could end up with cancer earlier than you, right? First and foremost, because I might have other risk factors that you may not have. I could have obesity, I could eat a lot of ultra processed food, I could have some familial link, not necessarily a known cancer gene with a very high risk, but I could have some tendency for DNA damage. So we really can't quantify that. So what we do know as doctors from the WHO is that these are carcinogens and they are absolutely unsafe in whatever quantity. So there is no safe limit for tobacco exposure. Similarly, this whole concept of an occasional drink or the cardioprotective effect that a glass of red wine has, everything has been debunked. So huge amounts of data from all over the world, hundreds of thousands of patients, very, very robust statistic shows that alcohol is very bad for you. There's no safe amount. It damages your DNA. So I think what we have to realize is that quitting is important. We have to acknowledge that quitting is difficult. We tend to think that, when I hit 30 or 40 or 50, I'm going to wake up and be able to kick the habit. It's not true. We are here to help you quit. There are ways to quit, but you have to acknowledge that you need to quit and, take the plunge. These are the important things that we have to think about. But if you haven't quit yet, you really need to go get yourself evaluated. You need cancer screening. One more thing that people also don't realize is that once you quit tobacco and alcohol, the cancer risk doesn't fall immediately. It takes nearly 10 years to plateau out. So it takes 10 years till you have not, gone anywhere near tobacco or alcohol, till your cancer risk is equivalent to someone who has never smoked or never drank.
Oh, that's new to me. I didn't know that.
Yeah, so that gives you an idea of how bad these things are for your DNA.
You are a head and neck oncologist, so I'm sure you get a lot of young, boyfriends.
Absolutely. Yeah, so the thing here is that the incidence of tobacco use in India is huge, right? So the global adult tobacco survey shows 1 in 3 adults uses tobacco in any form. And it's equivalent in urban and rural. We tend to think it's more rural, not true. We tend to think it's more men than women, also not true. So the incidence and penetrance of tobacco use is massive, right? There are multiple reasons for that, but there are effective ways to quit. And tobacco, even if you take cancer out of the equation, right? The argument I've heard from many intelligent people who smoke and drink is that, my grandfather smoked and drank till he was 80 or 90 and, he never had any issue. He died in his sleep. Even if you take cancer out of the equation, it damages every system. It causes strokes, it causes blindness, it causes heart attacks, it causes peripheral vascular disease, which means your vessels get blocked and you can lose your limb. It virtually damages every part of the human body. So there's nothing good it can do for you. So the best thing you can do basically is quit. And if you can get others to quit through your example, I think those are some definitely some karmic bonus points.
Yeah, absolutely. So, you're talking about cancer being detected early, and then then there is cure possible as
Yes,
well.
yes.
So, when you say early, is there any time that we give type train or anything according to the guidelines that we can talk?
So when we say early as oncologists, we mean stage. So stage 1, stage 2 would be early stage disease. Stage 3, stage 4 would be advanced disease. Stage 4 also sometimes colloquially people think means metastatic, which means the tumor has spread beyond the confinement of that organ and is all over. But under stage 4, you have metastatic and non-metastatic, which means it's locally advanced, but it hasn't spread to the bloodstream or the rest of the body. Again, here, depending on the type of cancer we are dealing with, the cure rates vary significantly. So if you are a young person with thyroid cancer, for example, even if you're filled from head to toe with cancer cells, you can be cured. So if you have metastatic thyroid cancer, if you're a person at the age of 55 who has lung metastasis, bone metastasis, your scan looks like a Christmas tree, you will still be alive at 20 years. And the reason for that is because we have remarkable treatments for many of the cancers. So we don't go by those numbers except for us to, I think, prognosticate the patient and tell them what the likely future is going to look like in terms of treatment and survival. But no two patients are alike. So we cannot with certainty say that all stage 1 patients are going to be cured or all stage 4 patients are not going to be cured. It's just about what kind of treatment they need, what kind of follow-up they need, and generally what the treatment process looks like.
Okay, so now that you're saying that each patient is different and the way each patient will react to a certain medication is also different, certain treatment is also different. So then how do you actually decide? Like a lot of people have this doubt that, oh, I was advised chemo and then, but somebody else was just given an injection and, sorry, no, the radiation and then this was not needed. So how do you actually as doctors define that? And also for patients to understand, how do you tell them that this is all you need and this is not that you need?
Good question. So the problem comes because cancer is a complex disease and biology is quite complex. So it's not mathematical, it's not binary, it's not ones and zeros, right? But I think the simplest way to look at that is to look at the guidelines. So we all more or less follow something called the NCCN, which are the National Comprehensive Cancer Network guidelines. It originated in the US, but we all have our, our local variations of that. So those guidelines basically tell us what the recommended treatments are for individual cancers and individual stages. So for example, you have a stage 1 oral cancer, the treatment is surgery. You have, a stage 1 vocal cord cancer, the treatment could be surgery, could be radiation. So based on the evidence, so what, sometimes people tend to forget is that when we treat patients with cancer, we have a lot of evidence compared to other diseases, So that is where we struggle a little bit to explain to patients is that all of this is backed by a lot of evidence. When we deal with pseudoscience, when we hear people talking about lemon and ginger curing cancer, it's a big problem for us, right? But what people really need to understand is that you may not read the data that we use to treat you, but it's there. There are clinical trials. There have been thousands of patients who have been treated in a certain way and then a different way, and then we compare those and then we say that this is the best way, this causes the longest survival, this causes the least side effects. There's a ton of data that we use to treat patients. And I think, that's really what we have, the message that we have to get across, that modern scientific treatment, especially for cancer, is based on a lot of high quality data. And that's why we treat you a certain way. That's why we don't look at you and look at your reports and say, why don't we try something else? It's just not done, and it shouldn't be done, because that's the best thing that we can do for that patient. And everything that we look through is the lens of what gives us the highest chance of cure and the least amount of side effects.
Like talking about side effects, what are some of the, these are some side effects that you definitely can expect in certain treatment options, like commonly used?
So, I think as oncologists, if we're honest to ourselves, all of our treatments have side effects. Nobody escapes without any side effects. But I think the cornerstone here for any sensible medical treatment is the risk-benefit ratio. So every treatment, whether it's surgery, even if we are stupendous surgeons and we pat ourselves on the back, our patients will have side effects after surgery. There could be mild side effects. It could be a little pain. It could be a little discomfort. If you're operating in the mouth, there could be some tingling in your tongue. It could be mild, or it could be severe. They could be life-threatening. Right? Similarly, radiation has local side effects. So radiotherapy is basically ionizing radiation. It damages the DNA of the cancer cells preferentially, because cancer cells multiply faster than your normal cells. Right? So what happens is you have more of local side effects. So you have some burning. You can have, for example, you can have sunburn-like changes. So you can have like a bad sunburn on your skin. Similarly, inside you can have mucositis, which is basically irritation of the lining of the mouth. You could have some difficulty swallowing. Then long term, you can have some dryness of the mouth. Again, you could have some swallowing difficulties. Chemotherapies and targeted therapies are given through the blood. So they basically circulate through the bloodstream. Again, cancer cells multiply faster than normal cells, and that's why preferentially their DNA is damaged, so they die off faster. But the cells that rapidly multiply in the body that are otherwise normal, our own cells that are not cancer cells, also can get damaged. So that's why our creatinine can go up. We can have some renal dysfunction. Our bone marrow cells that produce red blood cells, white blood cells, platelets, those can get affected, and we can have low white counts. We can have infections. Again, you can have mucositis. So it really depends on the kind of treatment that we're giving the patient and the general health of the patient before the treatment.
Right. So, there is this entry of a super, I would call it a Superman or something like that, the entry of AI into the, area of cancer detection, even treatment per se, and even your surgeries and robotic surgeries and things like. Has this come as an advantage? If yes, then what is the difference that you are seeing as being an oncologist for so many years, before AI and the scenario now with the advent of AI and interference of that?
I think it's fascinating, right? So the way that AI has changed our worlds has been transformational, and the way that it can potentially change the way that we deliver healthcare is also, transformative. So in routine healthcare, there are a lot of places where AI is already used. Radiology is a good example, right? So for patients who go into an emergency department, and you're worrying whether you had a stroke or didn't have a stroke, so a CT scan's been done of your brain, or looking for fractures, you've fallen, and the system is looking for a fracture. So artificial intelligence in general, as we apply it to healthcare, is very, very good for specific things. So for example, if we are to give the system a few thousand x-rays that are annotated, and we say this is what a fracture looks like and this is what a fracture doesn't look like, it can be trained, that AI model can be trained to a great degree of sensitivity or specificity to pick up a fracture. The reason why it's not yet the alpha and the omega, why it can be applied to everything, is because human beings are complex systems. So it's very good to answer particular issues, right? So we saw this in COVID as well, right? Picking up COVID from a chest x-ray or a CT, because we were looking specifically for COVID. But in general, human beings are complex, diseases are complex, the presentations are varied. So we don't see it, I think, at least in the next couple of decades, completely replacing doctors, simply because the way that we deliver healthcare, the way we interact with patients, is not necessarily the same way that an AI system would. you know. So, for example, a person comes in with a cough or a wheeze or something, that we do a chest x-ray, right? It could be any number of things. So you need a lot of information in order to make a diagnosis. It's not just, looking for a rib fracture or looking for a nodule that could be cancer or COVID. There's a lot of decision making that needs to be done. And AI decision making is really good when it's specific and it's in a very sterile, controlled environment. So surgery is the exact opposite of that. So surgery to some extent is a mechanical skill where you're trying to, perfect a particular task. But so much of surgery is decision making, So do you perform the surgery? Do you not perform the surgery? What is the abnormal part of the tissue that you cut out? Is it safe to proceed? Is there an anatomical variation? So there are a lot of things that need to be considered, and that is what AI will struggle with. So, for example, there has been a recent publication where there's been automated robotic surgery on an animal model, right? So basically, the robot was trained to join two pieces of intestine in an animal, and then human surgeons were basically competing against them, and they tested that. So the human surgeons lost by a huge margin. And I think it's interesting because, again, if you break down surgery into particular skills, if you're looking for technical proficiency, machines are going to be better. But if you look at the whole spectrum of what needs to be done for the patient, I think we are a long way away from, having that entire process automated. So I think that it can make us better clinicians. For example, you have a hover command with a human radiologist that is like a prompt saying, this could be COVID, this could be cancer, so that you don't miss it, right? Because humans fatigue, systems do not. In India, we're very overburdened, very overstretched. We see a lot more patients than we should, whether you're in the public or the private sector. That's one thing. And in surgery, the learning curve is something that can be very treacherous for complex surgery. So if you have, for example, a robotic system which is giving you prompts saying, maybe this is where you should be operating, this is where the tumor is, this could be an anatomical variation, I think that's incredible. So if we can have better efficiency, fewer complications for our patients, more time, money saved, fantastic, why not?
So it's like a combination that
Absolutely.
has to be right.
Absolutely.
So you have, there is a lot of zeal in you that you have to reach out to public and the public health. That concern is, I've been noticing a lot of work that you do in terms of reaching out and making it accessible, cancer care especially being accessible. So you have come up with something which is very, very interesting, the test which can actually detect cancer at an early stage. So if you could tell us about that.
So basically what that is, that also utilizes AI. So what it is it's basically a pretty simple piece of hardware that you could carry in a handbag or a backpack that digitizes images. So we have things already called slide scanners that are like document scanners, except they scan slides, which are very thin slices of tissue that we use for a diagnosis, or sometimes they're smears, which means that we take some cells and we brush them across, and then we get what's called a smear, which is a collection of cells, not like a chunk of tissue, but a collection of cells. So slide scanners exist. They're very good, but they're also very expensive, and they're very hard to use outside of a big fancy hospital. So even in a huge city like Bangalore, there are only a handful of hospitals that have these slide scanners, right? They're prohibitively expensive. So we built basically, Hardik and I, who's a scientist at the Indian Institute of Science, so we basically built a piece of hardware that would allow us to acquire these images with an inexpensive but accurate piece of hardware. So we could digitize these slides and we could scan those cells, send the abnormal cells across to a pathologist who was far away, and tell us if it was cancer or not. So we addressed, I guess, some of the inefficiencies in a slide scanner. So the one thing was the large size. We shrank it down considerably. The cost we've addressed again considerably. And the file sizes in a slide scanner are quite large. So a single high resolution scan could run into GB. So what we did is basically we extracted only the abnormal cells using AI and sent those across. So that can run even on a cell phone network. So you can have a 3G or a 4G network. You don't need a hardwired broadband connection or anything like that. So that's what we've been working on. There is a layer of intelligence for automated diagnosis of oral cancer, which is about 85% accurate. We're still working on it. So that's what we got the grant for. So the idea is that like radiology is accessible to everyone, right? So nowadays you go out, you get a scan, they send you the images on your phone, right? You get a little link in WhatsApp and you can go through your. So pathology has that same ability to be transformative, right? You can basically have access for the last mile for everybody, even in a tertiary or a quaternary center. But the two things that are missing are the hardware, because radiology, CT, MRI are generally standardized. So whether you buy, one company or the other, the equipment is standardized, number one, and number two is the imaging files are standardized. So wherever you do a scan, you can get a scan in Australia and you'll have an Indian radiologist reporting it for you. Pathology lacks that because we don't have that accessible equipment. So our idea was to build that, make it very affordable, very inexpensive but accurate, and then be able to generate the image. So we see that as a platform for early detection, not screening. So basically the idea is that if you have a lesion in your mouth, you can take a brush, run it through the machine, and you can have an answer in about 5-10 minutes. Typically what would happen is we used to go in a bus for these camps, spend hours and hours, see 100 patients, tell 10 of them, we think you have cancer, please come back with us to Bangalore for a biopsy. What we didn't understand at that time was coming back with us to Bangalore for a biopsy means you lose 2 or 3 days of wages. You have to have someone accompany you, which means they lose their wages, all because you think that they have cancer. So what happens is we used to see those same patients who had a stage 1 disease come back to us with stage 3 or stage 4. Because at that point it was symptomatic, they couldn't ignore it any longer. So the idea is now in India, I think we should really be focusing on point of care, which means we take this equipment out to the patient. We have to bring high quality diagnostics and technology outside of the hospital. So you take it to the patient side and you give them a fairly accurate idea then and there. So you should be able to say with a good amount of accuracy, yes, this looks like cancer. So then you can basically close the loop. So you can refer them to the closest district hospital that has cancer care. You can put them on to, either their ESI or their Ayushman Bharat or whatever form of insurance. So our test should be accurate enough for these insurance companies to accept it as proof of cancer. So that's what we are working on now, that validation, so that we are not saying you could have cancer, but this is cancer, this is the report, please get treated as soon as possible.
By when can we expect this?
So we have maybe another 2 years of work before we, are probably in a position to make it available. So I think the idea here is that we want to get it right.
I think it's going to be it's going to be a game changer definitely, because a lot of governments these days have these screening programs. Definitely, don't do your screening programs for NCD, non-partisan disease, and then we could definitely incorporate a screening of this.
So that's what so that's exactly what we want to do. We'd be very happy to work with the government. We'd be very happy to work with primary health centers and non-governmental organizations, basically to make this available. So rather than, having somebody take a biopsy and then sending that biopsy off and it's going to take 2 days or 3 days, you don't have the equipment, you don't have the personnel, you should be able to tell a person then or there whether they have a high likelihood of having cancer or not.
So I have some list of questions that are usually asked by our readers. We get it through our emails and things like that. So I'm just going to read out if we can quickly answer them in a very short time. So how do I know if a lump is cancer or something harmless?
You don't. You have to get it checked out, right? Because the cancerous lumps usually don't give us symptoms, right? The ones that are symptomatic, painful, cause irritation are usually non-cancerous when they're early. It's only when a cancer becomes advanced that it gives us a lot of local symptoms. So any lump that doesn't go away for more than 2 or 3 weeks, get it evaluated. Evaluation is two components. Usually it's some sort of imaging, can be something simple like an ultrasound or a CT or MRI, and a needle test. A needle test pulls out a few cells and that characterizes it. Does it look like cancer? Yes or no? If it doesn't look like cancer, does it look like an infection? Does it look like something else?
So again, like I said, you need to be observant about your body, and then here you have lumps, not just breast, right? There are people who look at only lumps in the breast, probably expecting, and especially women alone.
Correct.
So, lumps anywhere in the body.
I think that messaging for breast cancer has been great. So women are aware that if there's a lump in your breast, it could be cancer. We lag behind that in the other cancers. We think that it's something else, but we should be aware that a lump anywhere could be cancer. Get it checked out, and then you're free.
Yeah. So, this gives me another question on, since you deal with oral cancers as well, is there something that you can actually look at when you're brushing your teeth, or something which you need to regularly observe when you're looking at it?
Good question. So again, like you have self-breast examination, there's something called mouth self-examination. So most of us brush our teeth in front of the mirror. So we look for the simple signs of oral cancer. So those simple signs are, you could have an ulcer of some sort, you could have a red patch or a white patch, you could have a lump or a bump, you could have some difficulty opening the mouth, and you could have some loosening of teeth. Right? So these are all the symptoms of oral cancer. Any of these last, and of course bleeding gums. So if you have any of these that last for more than 2 weeks, get evaluated. It could be oral cancer. Even if you've never smoked, even if you never used tobacco in any form, never touched alcohol.
That was I was going to ask that. Should it be done even in people who don't smoke?
Absolutely. 10% of our patients with oral cancer have never touched tobacco or alcohol. So we have other risk factors as well.
Okay. So when you're talking about thyroid cancer, you were talking about how obesity is being linked.
Yes.
Obesity is being linked to a lot of cancers.
Yes.
Right? So the question here is, should I take that seriously and link it myself?
Absolutely. So I think, from a strictly medical point of view, it's very important that we are in a healthy weight. I don't mean how we look, that's not that important, but being in a healthy weight range is very important, because again, like tobacco, it impacts every system, right? So it increases your risk of heart attacks, it increases your risk of strokes. If you're overweight, it causes more pain on your joints, you have osteoarthritis. So these are things that we basically should look into, and WHO lists losing weight as one of the ways to prevent cancer. So if you're overweight, you're in an unhealthy weight range, you lose that unhealthy weight, then you can cut your risk of cancer and other diseases down significantly.
So is cancer hereditary, and should my family get tested if one person has it?
So most cancers are not hereditary. So among all the patients we see, only about 5 to 10% of them have basically a hereditary link, which means that there's a gene, an abnormal gene that is passed down from one parent to the next and one generation to the next. So the vast majority of patients with cancer, we don't do genetic testing for everybody, but we have very clear criteria when to do it. So when we have a cancer that's showing up in a young age group, right? Or you have a slightly advanced cancer. So we have different criteria depending on which cancer we are dealing with. And it's good to ask your doctor, your oncologist, and they'll advise screening for the rest of the family. But we have very good evidence-based criteria, so there's no need to panic. There's a very clear scenario when we don't need to screen the rest of the family or do genetic testing to see if they're at a higher risk for cancer.
Is there any paternal, maternal, that kind of?
Absolutely. So depending on the type of cancer that you have, some are X-linked, some are Y-linked. The most common that we see basically is the BRCA gene. So the breast and ovarian cancer gene basically is associated with breast, ovarian cancers, pancreatic cancers, and other cancers. So that usually is passed down matrilineally. You also have slightly rarer diseases, some of which are autosomal dominant. You have Lynch syndrome. So as oncologists, we know about it. Most people don't have to worry too much about it.
Okay, let's not scare them.
Absolutely.
Yeah. So do lifestyle habits like diet, stress, or phone radiation actually cause cancer?
Diet, definitely. So there's a higher risk of cancer with, ultra processed foods. There's more data that's coming up. Red meat, a higher quantity of red meat is linked to colorectal and other cancers. Stress, definitely. So there's something called epigenetics. So epigenetics basically means that the abnormalities that are expressed by the cell are impacted by the external environment. So stress is definitely one of those things that can, cause higher risks of cancer and other lifestyle diseases. So it's important that we learn to manage stress, we learn to manage our diet. Cell phone radiation, probably not. There's not much strong data that's linked to that. It's more ionizing radiation. So, multiple CT scans, not so much, but if you have a lot of CT scans, earlier radiotherapy was used for non-cancer related problems like acne. Thankfully, we don't do that anymore. And of course, if you have radiotherapy for one cancer, there's a chance you could develop a new cancer. But again, risk benefit ratio. So if you need the radiotherapy, please take the radiotherapy, because the risk from the cancer that you have is much more than a second cancer that may or may not pop up down the track.
So a lot of people have this belief that I've been asked to do an X-ray, or I've been asked to do a particular kind of CT or whatever. So then they're scared that they'll get cancer and they know. So is there like you said repetitive exposure, but is there any number?
So the dose, there is basically a dose dependency. The radiation dose from an individual scan is minuscule. Okay, so definitely from a couple of CT scans or MRIs, you will not get that. There's nothing really to be worried about. The main concern for us as doctors is the patient population that ends up needing a large number of CT scans. Ironically, our cancer survivors who need to be on multiple surveillance scans, or people who need to get repeated scans for other reasons, but we usually mitigate that. MRI, for example, doesn't have any ionizing radiation. So from individual X-rays, individual CT scans, absolutely not.
Okay. So are there any particular signs that a doctor, a physician himself or herself could miss in detection of cancer? Any warning sign that you have noticed that this is something physician could have gone?
So I think basically what happens is these symptoms are very varied and very subjective, right? So if three of us have the same tumor, based on our lived experience, our pain threshold, and our lifestyle might have completely different symptoms. So we are complex systems, basically, right? What makes somebody jump out of a chair in pain, another person may be very comfortable with that level of discomfort, right? So I think basically, if you feel that something's not right, you're not feeling well, and you've gone to a physician, you've gone to a surgeon, the problem hasn't gone away, go back to them. Go back to them. Make them aware that you want evaluation, because sometimes there is a concern that we overdo it with, investigations and things like that. We don't necessarily ask everybody at the very first symptom to get a full battery of tests because it may not be indicated. But if you have anything that's troubling you and it's not going away with medication or it's persisting, go back and get the test done. Speak to the surgeon, speak to the physician, tell them you're not feeling okay, it's not settled down, that you want evaluation, and get the evaluation done.
One cancer myth you wish should just disappear.
Biopsies spread cancer. That's what a lot of people think. A lot of people don't get biopsies because they think it spreads the cancer. Absolutely not true.
Okay, yeah, that's very true. One breakthrough in cancer care that you're most excited about right now?
I think immunotherapy, guarded with a little bit of guarded, excitement, let me say. We are moving to a point of personalized medicine where hopefully we can do a lot less of these huge complex surgeries. We are hoping that, 10, 20 years from now, we'll be able to shrink the tumor down, do smaller surgeries, or do away with surgery, in head and neck cancer. We've seen that trend in other cancers. We are hoping that in head and neck cancer that comes as well. So I think immunotherapy, personalized medicine, as we get more and more data, AI helps us sift through the large amounts of data and helps us interpret it better. We are moving more towards, treatments that are more specific. So we're not going by the guideline. We are moving towards say like a nomogram, which means we are not saying that for a stage 1 oral cancer treatment is surgery. We are saying, for example, that you are a younger patient without tobacco or alcohol. This is the marker that your tumor expresses on the biopsy. You're probably going to do very well with radiation and we don't need surgery. So we have that in other cancers. We have that nuance, right? Be it prostate, be it breast. We've reached that level of maturity. I hope for head and neck cancer, we'll get there soon.
Precision medicine. Then.
Absolutely. Absolutely.
So, the most underestimated cancer in India?
I would say mouth cancer. You know that I'm very biased because that's what I treat morning, afternoon, and night. But unfortunately, the messaging for tobacco causing mouth cancer and that stigma of the link between tobacco and oral cancer makes most people think that it's not cancer if they've never chewed tobacco or they've never smoked. So there are non-squamous cancers, which means we have salivary gland tumors. Sometimes we have tumors of the muscle or the bone, we call sarcomas. Those sometimes present even in children. But since we are not aware of these, and the head and neck is generally a very complex anatomy, right? For us to understand, even for doctors to understand its complex anatomy, we miss a lot of these. And then by the time we end up going for treatment, it ends up as a long drawn, complex treatment process.
I have two more questions. One is one mistake people make right after a diagnosis. They've been diagnosed, then there's one mistake that they usually.
I think panic and anxiety is normal, so that's definitely not a mistake. I think going to unverified sources of information for comfort, right? I think a vast majority of my patients now run everything what I say through GPT. I don't think that's a bad thing. I think it's good that patients have access to information, but the caveat here is that you need trusted, verifiable medical information, right? So I wouldn't fix my own car. I would definitely trust a mechanic to do that. So I don't know why you would trust a random person on the internet to advise you about surgery. I think what happens also is because of the, emotions around the diagnosis of cancer, that a lot of patients end up moving from doctor to doctor, hoping to get, a different opinion. So if somebody doesn't want surgery, they're basically trying to find somebody who will offer them an alternative. Or if somebody really dislikes chemo, but chemo is the way to go, they'll go to a surgeon, who agrees to operate them. So I think it's a complex problem. I think now the wonderful thing is that we have access to information. So find out what the guidelines are, very simple, Google them, figure out what the right treatment is, and then go with someone you trust. Everything won't be perfect, but definitely go with someone you trust. If you don't trust the doctor, don't get treated with them. I think that oncologists will be happier that you get treated with somebody who you trust, because that trust is really important. It's going to be an up and down, process. So you need to trust your doctor. You need to be compliant. Very, very important. So I think basically stick to the data that we have and trust in the process.
So this, I have two questions. Sorry again. One is, basically, let's accept that cancer care treatment especially is expensive.
Absolutely.
There's no doubt about it. There's no discussion on that. But what would you tell patients to actually, ensure that you go for treatment? So what is the best thing to do for them?
Buy insurance. So cancer treatment is not meant to be paid out of pocket, right? So a few years ago, most people didn't have health insurance. It's a little better now with COVID. Post-COVID, people realize that, healthcare expenditure is massive. So as surgeons, we can say, okay, we are happy to waive off our charges, but there's some things that we can't control. The cost of the equipment that we use, the consumables that we use. So what you see basically is just the tip of the iceberg. All of these things cost money, and they're extensive supply chains. Things are manufactured all over the world. The profit margins are absolutely not in our hand. So the simplest thing is to buy health insurance, because what that means is that health insurance coverage takes care of at least a chunk of your treatment, and the amount of money that you have to spend out of pocket is minimal. India is the capital of the world for out-of-pocket health expenditure and what we call shamefully generational healthcare debt, which means that one bad hospitalization is enough to send not only this generation but the next generation into that. So we need to realize that somebody in the family getting ill and spending a lot of money on the treatment is the rule, not the exception, right? We are getting, pretty unwell as a society. So prepare for that, get health insurance, get coverage. So at least there's a buffer. You don't have to spend a lot of money out of your own pocket.
My last question. If cancer could speak, what would it tell people today?
An interesting question. Maybe I'm a part of you. So the reason why we have trouble getting rid of cancer and eradicating cancer, like we've eradicated polio, we've eradicated filaria, other diseases, we've completely done away with them. The reason why we can probably not do that with cancer is because, again, cancer is the price we pay for being complex, organisms. They're very much a part of us. They're very much DNA damage is an eventuality. It's not a likelihood. So it's likely that we all end up with cancer in our society. So we have to deal with it. We should not be afraid. We have to treat it, acknowledge it as a nemesis and deal with it. It's not likely to go anywhere, but we accept it as a fact of life. It's a cost of being, an older society, higher incidence of cancer. If we're living longer, we are going to have a higher incidence of cancer. It's here to stay. So accept it and deal with it. Hopefully it becomes a chronic condition. So what we want as oncologists is for us to view it as a chronic condition like diabetes, like hypertension. You're on medication or some form of treatment and it's under control. So that your lifespan is adequate. It's not shortening your lifespan. It's not threatening your quality of life, but it's a disease that you're managing.
Thank you very much. That was Dr. Narayana Subramaniam, lead consultant, head and neck surgery and oncology at Aster International Institute of Oncology.
Thank you very much.
Thank you
Thank you
very much.
Thanks a lot.